Good afternoon. Well, thank you very much. Thank you very much for inviting me and giving me a chance to see my old dear friend, Mo. It's just a delight to see you. I'm going to talk about pregnancy and postpartum. I think that it is not surprising to anybody who deals with women to find that pregnancy is not a protected time. In fact, women can and often do experience depression in pregnancy. In the same way that if you happen to have a psychotic disorder, it doesn't go away in pregnancy and it can be more extreme. Now, if these kind of disorders are mild, certainly there's a huge role, and this is not an either or presentation. So there are many psychological issues that come up during pregnancy that can cause people to feel distressed or unhappy. Even if people need medication, they can also benefit from support or specific techniques like CBT. But the reality is that sometimes people need more and they need medication. So we know very much that if people have been on medication prior to pregnancy and they discontinue it, the chance of their having a resurgence of their symptoms and the risk of relapse, 50% by the first trimester and 90% by the second trimester. So it becomes very important to realize that this is counter to what a lot of women are either told, oh, if you're going to get pregnant, you have to go off your medication, or that women believe themselves. So this is very important to realize that we often do need to use medication. Primary care providers can do this as well. I mean, there are obviously some very complicated psychotic illnesses that may need an extra hand, but for most primary care providers, this is when the woman's going to first appear talking about her symptoms, and the treatment is not really complicated. It just requires more than anything else, education of your patient. And I certainly agree with Mo that if you want your patient to be on side, you've got to help them to understand, because especially with psychiatric drugs, people say, I don't take any drugs during pregnancy. Well, they take digitalis if they've got heart problems, they take an antibiotic if they've got an infection, they take thyroid or insulin. It's psychiatric drugs that they're all very wary of. So how do we go about helping our patients to understand that this is important? I think there are two ways of doing it. First of all, I think that all life is a risk-benefit sort of decision that we're making. So it's very important to help people realize that there are risks of not taking medication. And of course, people are very depressed or very anxious. They can try to commit suicide. They can attempt to self-abort. They don't eat well. They don't go for proper prenatal care. They may have used alcohol or other substances. We see increased cortisol levels in the infants. And certainly we see the infants can have low APGAR and require more an admission to the NICU. There's also an increased risk of preterm birth. Low birth weight, SGA, preeclampsia, spontaneous abortion, and the biggest risk for getting a postpartum depression is being anxious or depressed during pregnancy. So it's very important to help people realize it's not so simple as, well, I'll just tough it out for the sake of the baby. To help them realize you're actually putting your baby into jeopardy if you don't treat the depression or anxiety during pregnancy. As well, there's been some very recent research that talked about maternal stress in general, significantly predicted shorter newborn telomeres. And telomeres, these are the important things that just lead to lifetime increases in, if you've got longer telomeres, you're more likely to be healthy and do well in life. So more and more evidence that we can't just suck it up and think we're protecting the baby by not treating things. Now, the difficulty is, of course, that, when you tell people about taking medication, they'll go online or they'll talk to people or they'll Google things. And it's very important to realize that it's very complicated for somebody who isn't sophisticated about looking at studies to understand what they're seeing. To understand what's the difference between what a drug's causing versus what's in the community. If I see a drug and they say, oh, well, there had some defects when people take it. There are zillions of papers about issues that drugs cause during pregnancy, but most of them are very flawed research. And, they don't look at all the very many confounding variables, the diagnosis, the maternal age, the reproductive history, substance abuse, prenatal care. So what we need to do is help educate our patients. And it's important for us as well to do a critical review of the literature. We're all guilty about looking at a paper and seeing the abstract and saying, oh, okay, well, that's now I know this and now I'm going to change my practice. But there's so many papers with defective methodology out there that it's really important to look at why they're coming to this conclusion. So when people talk about concerns about taking drugs during pregnancy, there's several areas they're concerned about. First of all, fetal loss, pterogenicity, problems during labor, problems for the neonate, and long-term problems. So let me do a sort of rundown in addressing all the sort of things that we know in terms of safety, things that we're still concerned about, and drugs that we feel comfortable with, and drugs that we still don't know a lot about. So first of all, in terms of pregnancy loss, and I think this is a good example of if people are not informed about reading the information and the literature, they can get completely messed up kind of view. So, original papers would talk about tricyclics caused 10% of miscarriage, and SSRIs caused 13% of miscarriage. Now, any of you who are involved in obstetrics know, well, the average rate of miscarriage is 18 to 20%. So I guess we should put all our pregnant patients on antidepressants to lower their miscarriage rate. So you see that this kind of information is meaningless if you don't have a context for it. And in fact, when they do proper meta-analyses, none of these drugs are associated with an increased risk of miscarriage. The same with antipsychotics, we're not seeing any increased risk with those. And again, it's confusing because just being psychotic leads to a high-risk pregnancy. There are things that go on even if you're not on medication. So very important to distinguish between the effects of the medication. Now, what about teratogenesis? So again, it's very important to realize that there are two main things to look at. One is that there is a baseline in the population of 3% defects. So if you just look at all the babies who are born, 3% of them may not have a major thing, but they'll have something. So in order to prove that a drug is doing something, it has to go above that 3%. The second is whether they have a distinctive pattern. When they put up thalidomide and all of a sudden kids started being born with these weird limb defects that nobody had ever seen, it wasn't too hard to figure out what was causing it because that was so unusual. But with most of the drugs that we see, they'll see, okay, a paper report, oh, well, there's defects from this drug. There was one club foot and there was one heart problem and there's one this or that. That is not a pattern. That is just a random assessment that you're going to see whether people are on drugs or not on drugs. So if we look at critically then the research, we find, first of all, that our typical antipsychotics all tend to be safe. We don't see any significant teratogenesis. Our atypical antipsychotics Any studies have shown either there's no increase or there's no typical pattern. Again, you see a scattering of things. There are some concerns about that gestational diabetes and weight gain and infant birth weight, but it's not teratogenesis that you're seeing with that. With our benzos, again, we don't see teratogenesis, although some recent research we've been involved with. You do not want to have people on benzos regularly. Doesn't mean that, if they're having some panic attacks, they can't occasionally take, some small doses of lorazepam. But we see an increased risk of preterm birth and SGA and attendance in the NICU if they're on regularly. The same with our sleeping agents, zopiclone and zopiderm. Again, no teratogenesis, but some increased risk of some difficulties with the baby in other ways. Our antidepressants, most of our TCAs, our SSRIs, bupropion, mirtazapine, venlafaxine, trazodone, we're not seeing any difficulties. I'm sorry, Mo, but the issue with newer antidepressants is we don't know as much. There's no clear evidence that they are harmful, but there's no very extensive evidence that they're safe. So generally, if you were going to use start a drug, start with something that we know is safe. Now, we generally believe if you see somebody and they've been on 5 different antidepressants and vortioxetine is the only one that works, then go with that. That's more important to not be depressed. And as I said, we don't know of any true cases that there are problems from that, need more research. In terms of our mood stabilizers, a favorite one is lamotrigine. Now, lamotrigine has 2.2% of non-syndromal clefts. And what that means is that some babies under 3%, under that key figure, might have a cleft palate, but it isn't indicative of more general difficulties. And we know how to fix cleft palates. So, if that's the worst case, then that's a problem. Carbamazepine, some people use. I don't use it. I find it's just a little over that 3%, and that's a problem. Some questions come up of some sort of difficulties. Paroxetine is one of the drugs that they've talked about having cardiac defects. So there was a study done by Melm, and he says there was a 0.2% increase in RV tract defects. But if you look at the study, many calculations, and in a key way, 90% spontaneously remit. And so Einerson looked at that and she said, this is silly. If you're talking about transient defects, who cares? I mean, it really is a question of whether this is a severe cardiac problem that's going to last. And everybody got sort of excited about this study and started looking at the various cardiac studies for any of the drugs. But you have to keep in mind what happens. So first of all of these drugs are retrospective. All of these studies are retrospective. And very often in these studies, there's no evidence that people actually took the drug. In fact, we know very clearly that often women are giving a prescription, but they don't take it because they're scared to take it. And so, you're making an assumption that they actually took the drug all this time. Once people are on drugs, everybody looks at them more closely. They look at those babies more closely. We don't have population data for a lot of these things. We only know, okay, well, in these women who are on this drug, we think they had more than what, if we don't know what the general population is. And in these cases, many of those ventral septal defects close spontaneously. So again, is that anything to worry about? So the latest meta-analysis is that in prospective studies, as well as retrospective studies and case control studies, there's no significant increase in the risk of cardiac malformations after first trimester exposure to an antidepressant. Now, let's look at some of the things that are of concern. Lithium, now lithium's interesting because we actually used to be far more worried about lithium with Epstein's anomaly, and the original registries seem to show a very high rate of Epstein's anomaly. But it's the problem with registries. You know, I have seen thousands of women in pregnancy. I have never reported to any registry about how they did at being normal. So the only people who get reported to registries is if something goes wrong with the baby. And the assumption is then, oh, it must be the drug. You know, the woman was on lithium, and so this happened, so it must be the drug. So there's a distorted basis that you know the numerator, you don't know the denominator. You don't know how many women were actually on this drug. You only know the small number of people that reported in. And so in the last little while, they analyzed this, and they felt that the risk of that anomaly was only 0.01%. So it's really not a very high risk if you really need lithium. Now, valproic acid is witch's brew. You know, in France, they're not even allowed to prescribe valproic acid for women. And I would never give a woman valproic acid because, first of all, they can increase the rate of PCOS. So, oh, lucky you, you know, you help her mood and you make her infertile. If she is taking it and she wants to get pregnant, get her off of it. It is a terrible drug. It causes spina bifida, craniofacial defects, atrial septal defects. It's a terrible drug that shouldn't be given to women. And some of these others, like topiramate, is also something that can have over 5% defects. So stay away from these drugs. People don't use diazepam very much. There was some early research that said it had cleft palate. But if you look at the statistics, it was interesting. Although they were saying that, and there was a period of time where almost every woman was being prescribed diazepam, there was no increase in the population in cleft palate. So that was probably not very accurate. MAOIs are not actually teratogens, but the fact is that it's very risky because if you eat the wrong food and you suddenly get you know, huge increase of blood pressure, that can cause a placental abruption. So they're very risky. So what about during labor? Well, we want to stay away from heavy loads of benzos, and they don't really give that anymore. That was old-fashioned kind of things. You don't want the neonate to be too sedated. Atypicals, the one thing, if you're an obstetrician, to watch out for is that the baby can be bigger. They can gain more weight, and you can get into shoulder dystocia and birth injuries. So if they're not prepared to that. So this is a matter of, you know, making sure that if you are treating a woman with this, that the obstetrician knows what she's on. It doesn't mean she can't be on it, but they should know what she's on and judge whether she can deliver vaginally or not. What about the effects on the neonate? Well, there's no increase in stillbirth or neonatal or postnatal death. One of the things to be aware of is that the infant can't process drugs as well because of poor liver enzymes and incomplete blood-brain barriers. Now, people have talked about, you know, some withdrawal that some people have, some babies have from major tranquilizers, and perinatal syndrome has been described, but it's very rare, it's transient, it lasts for a few days. Lithium is something, again, if the mother's been on lithium, it's important to watch the baby because babies often lose weight quickly after the birth. And so, you know, you have to be careful that their lithium level doesn't increase at that time. Anxiolytics, not a good idea. Poor temperature regulation because the baby can't process them. Now, with SSRIs, you know, there is a description of all these terrible things SSRIs can do. So birth weight could be 75 grams less. The duration of gestation could be 3 days less. Most women would be very happy to deliver 3 days earlier. So, and no prematurity. In neonatal adaptation syndrome has been described, and the rates of it, you know, first of all, they said 30% as you go along, those rates have been falling. Of the women that I've seen, and again, I've seen thousands of women, and we have a huge obstetrical department in our hospital. They see about 8,000 births a year, and they say, we don't see this. I have never seen this. So I don't know who these babies are. But the whole point of it is, even if there is a bit of what's probably a withdrawal syndrome, it's a transient kind of thing. The only thing that's suggested is put the baby in a quiet, low light room, skin to skin contact, and everything will be fine. So it's not something to be worried about. There's a few more serious things that have been talked about. Persistent pulmonary hypertension, very rare disorder, occurs in 0.1% of neonates. They did a study and they found what was interesting about it was this was people who had SSRIs in their last trimester. There have been then some studies, 3 said they're positive, 3 said they're negative. And overall, what is probably felt is it really an issue, or is it the depression that might be causing this? Overall, again, the risk of not treating are higher than the risk of this. In terms of long-term effects, again, valproic acid is a vicious thing. It can cause impaired cognitive function and impaired language skills, so stay away from it. We don't see any problems with SSRIs or venlafaxine. There was one study that talked about ADHD with bupropion, but they didn't look at family history, which is a key kind of thing. Now, people are always looking for something to find. And so in the past few years, there have been studies about a relationship with SSRIs and ASD. There have been a lot of studies, and you'd find even studies which use the same data set would come up with different results. None of these studies showed risk greater than 2%. But there are significant differences in all of this. First of all, problems with diagnosis. None of these studies were studies just for them. They used other data sets, which didn't necessarily ask all the right questions. And sometimes a child might be referred at one age with a tentative diagnosis, which is not really valid. And since the APA changed things so that it used to be, you know, Asperger's and then really serious autism, now it's autism spectrum disorder. I don't even know what it means. 1 out of 65 kids is being diagnosed with ASD now. So to me, that's in the realm of normal. So I don't even know what they're measuring in these studies. There's in all of these studies, there's the assumption that the drug was taken. We know there's a genetic overlap between depression and ASD. And a lot of the studies didn't look at all the other variables that should be considered, like the other children, the father, postpartum problems. And again, we have the issue of mothers on meds are more carefully followed. Some recent studies have shown no significant association between prenatal antidepressant use and ASD. And what was a really interesting study was they looked at women who had been on medication and discontinued it up to 6 months before pregnancy. And they had a higher risk of ASD in depressed women who were not on meds. So it couldn't be the medication that was causing this. And this started people thinking, it's the severity of the depression. Why are people on meds in the first place? Because they have a severe depression. So if anything, what this points out is that we are really under-treating these women. So ASD is multifactorial, all sorts of things. And any relationship is minimal and most likely related to severity of depression. I'm just going to quickly do postpartum disorders. So we know that postpartum, we see major depression in about 10% of women. psychosis in 0.1%. If people have a history of bipolar disorder, they're especially vulnerable, even a family history of getting depression or hypomania postpartum. So the question is, can we use drugs in breastfeeding? This gorgeous woman is my daughter, and this little cutie is my grandson. So I use this just to illustrate that my daughter is prone to depression, and she took medication throughout pregnancy and during breastfeeding. Now, all psychotropic drugs pass into the milk, but the question is how much. So with typicals less than 3%, atypicals less than 5%, antidepressants, often it's not even a measurable amount that we see. You know, nothing's going to tell us what the effects are in 20 years, because first of all, you have kids, the mother's on meds because she might have some genetic problems, which you pass down to the kids. And there's so many variables in 20 years, who can tell that it had anything to do with breastfeeding? But certainly at the time, we don't see short-term effects. We don't see difficulties with the infant. If the mother is not taking medication, we do see problems, because poor infant care and rejection of the infant, or she's not eating properly, or the parents are fighting, or she can feel suicidal or homicidal, and end up with long-term guilt. So the worst thing that I see is a depressed woman who can't even make eye contact with her baby, but she's trying to breastfeed because she thinks that's important, and to not take medication to do it. She's doing far more harm to herself and the relationship. So we don't see any harm with all of these things. Even ironically, valproic acid is actually safe during breastfeeding, but again, I think it's a drug we should stay away from. We certainly want to stay away from benzos because the baby can't metabolize them, and so can get jaundice and poor temperature regulation. Lithium is a big problem because babies easily throw up or they have diarrhea, and all of a sudden you have to worry about whether they've then got toxic levels in their bloodstream. So in terms of long-term effects of all the drugs I've talked about, we've got children who've been assessed when they've been taking medication throughout pregnancy and postpartum. They've been assessed up to 86 months afterwards, after birth, and there's no effect on global IQ or language development or behavior. So in summary, first of all, pregnancy is not a protected time. It's possible and often necessary to use psychotropic drugs during pregnancy and during breastfeeding. If you discontinue the meds, there's a high risk of relapse. And there's less evidence of harm from the medication than harm from the illness. And this gorgeous creature is the 12-year-old version of that little baby, my grandson, who is actually a student at our National Ballet School, going to be a ballet dancer. And there's absolutely nothing wrong with him. I'll just do a little advertising if I could. So this book, Postpartum Mental Health Disorders Case Book, is a book that my group at the Group for Advancement of Psychiatry has published. And it's very useful for primary practice people or nurses or students or whatever. It's based on a case model. So we give vignettes of different kind of cases and then talk about possible differential diagnoses and management, what you can do and when you should refer. So might be something that's of interest for some of you people. So thank you very much.